Hello, my name is Jesse Dawson, and I'm a professor of stroke medicine from the University of Glasgow. And thank you very much for joining us today. And I'm delighted to have with me Professor Dr. Gerloff, who's going to tell us some really interesting results about a recently concluded trial looking at transcranial direct current stimulation. But first of all, Dr. Gerloff, just tell us a little bit about yourself and where you're based.
Yeah, hi, Jesse. So my name is Gerloff. I'm based in Hamburg in Germany, and I'm a professor of neurology, specialized in stroke. And for many years, I've been interested in the neuroregeneration after stroke, neuroplasticity, basic science on neuroplasticity in humans, but also neurostimulation interventional trials. And the trial that we are going to talk about is one of the major trials that we did on this topic. And today I'm here as the speaker of the NETS trial collaboration team. So it's definitely a huge group that is responsible for the trial.
Absolutely. And they're very difficult trials to run, for sure. And first of all, though, before we get into the specifics of the trial, just tell us a little bit about the clinical problem that the trial was trying to answer.
So the biggest thing is that upper extremity dysfunction is very frequent after stroke and does often not recover very well. So we have half of the patients or more that have a remaining deficit in the upper extremity function, and that this is really a hurdle for reintegration into activities of daily living. So this is where we started. And our goal was to use neurostimulation non-invasively in order to enhance plasticity of the motor cortex in the stroke hemisphere in order to facilitate recovery processes in the motor cortex and around the motor cortex. There's some basic data that this can work, and we wanted to try it in a clinical setting with a randomized trial.
Excellent. So, and tell us just a little bit about the design of the trial then. So who did you pick and what exactly was the stimulation intervention that you used?
So the idea was to start as early as possible and feasible and safe. So we decided not maybe in the first day, but after 5 days, we started recruiting. And at first, we wanted to really have only between 5 days after stroke and 20 days after stroke, so an early subacute phase. Because of very slow recruitment, we had to extend it a bit. So we went up to a maximum of 45 days to recruit patients with ischemic stroke. On average, patients were recruited after 20 days. So it was actually still in the subacute phase. So this was the population. And the major criterion for inclusion was an upper extremity deficit measured in the Fugl-Meyer. And patients needed to be able to perform rehabilitative training because we combined this stimulation with training. So it was the idea to create an environment where there's a very standardized, intense rehabilitative training in one arm plus TDCS and the other arm placebo stimulation.
Okay. And just to quickly pick up on the placebo stimulation, was there a sham stimulation used?
Yes, absolutely. Yeah. We used the sham stimulation, and it was pre-programmed in these stimulators. They just give a code, and so nobody knew what kind of program was running. And in order to exclude that the patients feel anything, we had this usual ramping up of the current, ramping down of the current over 8 seconds. And in the active condition, the current was running for 20 minutes. In the other condition, only for a few seconds, and then ramped down. And we know this from many trials that patients or subjects cannot differentiate that.
Yeah, sure. Excellent. Okay, and in terms of just one more thing about design, when was your main outcome measure taken? What was the kind of primary outcome time point?
That's a very good question. So when we were very young and enthusiastic about the trial ran 10 years. So we wanted to have a super solid outcome, say, after 1 year, for example. Okay. But then, on the long run, we realized that this doesn't make any sense because after the end of the intervention, there are so many things happening. People go in rehab, go several times in rehab. People go and have no support. So we said, no, we have to see if the stimulation does anything. So we did it right after the end of the intervention. The intervention was 10 sessions, 10 working days over 2 weeks. And then the next day, or at a maximum of 7 days after this intervention, that was the time of the primary outcome.
Yeah. Okay. And so tell us a bit about the main results of the study then. What did it show?
So first of all, it showed that our patients had a real nice recovery curve. And they improved approximately 9 points on the Vogelmeier-Arm score in the first 14 days. And if this is the intention to treat analysis, and in the per protocol analysis, it's like 10.2 point scores on the FMA, upper extremity Vogelmeier. Unfortunately, in both groups with stimulation and with placebo, it was pretty much exactly the same.
Okay.
So there was absolutely no significant difference in this primary endpoint, no matter if it was intention to treat or per protocol.
Mm-hmm. And have you had a chance to look at the data to see if there were any signals of subgroups that may have had more or less benefit?
To be honest, we really went for deep phenotyping, if you want so, and we looked at multiple scores, ARAD, box and blocks, 9-hole peg test, and also including stroke impact scale, PHQ-9, all these things, and this at this first time point, then at 30 days, at 90 days, and 1 year. And there was nothing whatsoever.
Mm-hmm.
No effect, also not in subgroups and not on secondary endpoints, nothing solid.
Okay. So I guess thinking about what that means, I mean, do you interpret that as meaning that TDCS isn't going to be a benefit in stroke rehabilitation, or do you think it's still an unanswered question?
I absolutely think it's a non-answered question. I mean, we used one way to address this topic, and as with so many other medical interventions, there are 10,000 other ways to do this. And we definitely have a very solid data set. So we can reliably say that the way we did it, it is not working, which means 1 milliamp combined with therapy. We can talk about this maybe later, what are possible reasons for failure of the trial in that sense. But there is also a possibility that you're more successful in these elderly people with a stroke if you use higher amplitudes, slightly higher amplitudes at least. Or maybe we were too late by extending the time window. But on the other hand, we have really nice data from proof of concept trials in the chronic phase. So you can also say maybe we were too early. Mm-hmm. We could also say, well, first you need to use the natural recovery plus intensive training. And then there comes a moment where you can actually superimpose brain stimulation. So what we know from the trial is it's safe. We had no seizures, no events, nothing that the Data Monitoring Safety Board was worried about. And in that sense, I think one can stay in the early phase. I would probably also tend so, but we don't really know. And the other thing is maybe we have to individualize it more. You know, it's difficult enough to include patients randomized in this kind of trial in a multi-center prospective way, but still, you may have to look at different anatomical parameters, pyramidal tract integrity. So there are multiple questions that are still open, and I absolutely think that TDCS could still work.
Mm-hmm. Yeah. And I guess thinking about the natural recovery, were you surprised by the amount of natural recovery in the trial?
We had a great discussion about this because in the beginning I said, wow, so in these 12 months, they were getting really good. I mean, the average NIH stroke scale score was 4, approximately 4. And they really recovered well. Yeah. And according to this proportional recovery rule, still after 12 months, the proportional recovery was more like in the mid 50% or so, but there's way to go. And in both groups. So I was not, at first not, but then we looked we had this handbook for the physiotherapy and rehabilitation training, and that is super intense in both arms. Mm-hmm. So, and we had many excellent physiotherapists involved. So there's a possibility that really this structured training program that we applied to both arms was actually creating a kind of a ceiling effect.
Yeah.
So it may be in reality, when patients do not go through this extremely intense training, there's more room for improvement by neurostimulation.
Yeah, and I think that's an encouraging message, that we can actually see big improvements in people by just giving lots of intensive physiotherapy. And I think that's a lesson in itself, isn't it?
Absolutely.
I think one final question then, kind of pulling everything together, what would you like to do next? If you can be sort of a bit clearer on who would you study, and would you change the intervention to give more sessions or different current, or all of those things?
Let me answer the question maybe slightly differently. What was the most challenging part of this trial was the slow recruitment, and that it took about 10 years. So I think what we really have to think about is how to establish international networks to implement trials like this much faster, much more effectively. And then we can also start thinking about different groups of patients, because if I can recruit 500 patients in 3 years or in 2 years, then I could have gone with, for example, I would now introduce one arm in the study that is not going through this kind of intensive physiotherapy treatment. That would be the first thing. And then I would probably go for a higher intensity, because I feel it is safe and we could definitely use that. And TDCS is still one of the candidates I like because it is feasible. So you can really have this battery-driven device in the rehab hospital. If you start and say, well, everybody needs neuronavigated transcranial magnetic stimulation, then I'm afraid that it will not be implemented in the clinical routine.
Yeah, absolutely. No, indeed. Well, listen, thank you very much for talking to us, and congratulations on getting the trial concluded. They're really difficult trials to do, and to get it to completion and to get, a high quality data set that can be used to inform future work is still a great achievement. So well done, and thanks again for talking to us, and I hope you enjoy the meeting along with everybody else. So thank you.
Thank you very much. The credits go all to the trial team, which has done a wonderful job, and to the patients and their relatives. Thank you.
Absolutely. Thank you.